I think you can see it. Now let's recognize the organ again. Those would be actually structures of a lung. Here we see lots of alveolar spaces. Here we see alveolar septi, some small portions of, well, small portions of inflammatory cells might be observed. And what we see here is very interesting dilation in the bronchi. First, cartilage here. Is that a bronchus here? Is that a bronchus? What is that? Does it appear like a bronchus? Is it covered by respiratory epithelium? It's covered by just one layer of cells, smashed, smooth cells. These are, yes, that is a huge blood vessels, thank you. So, do not mistake it with the bronchus. Although it appears huge, although it appears with multiple layers, it's not necessarily a bronchus. Take a look at the inner covering of a vessel. It's fine. It's fine. Don't worry. I know that your connection is interrupting. I hope this wouldn't happen on the day of your exam, but we will do everything we can to keep your answers so that we'll continue further with your tests. I hope that everything will be fine. What else here, which is quite important? Now take a look at the dilated vessels again, which are lacking amounts of erythrocytes on the inside, but always to judge a vessel and to divide this way, you should be able to see the covering of the vessel. Now take a look at this structure here. First, the bronchus is enlarged. It's completely quite enlarged. It's a huge one because it's covered with respiratory epithelium. Yes, it's having lots of smooth muscle fibers on the inside, inflammatory, not inflammatory, but vessels filled with erythrocytes, some inflammatory cells. These are glandular structures which are usual and are producing mucin next to the bronchi, which are actually leaking out inside in the bronchi. And along with the secretion with the goblet cells, they build specific secretion which washes away all bacteria and foreign particles, which is actually a defensive barrier against all of these. These are small amounts of anthracotic pigment. Some emphysematous changes at the border of the slide due to alveolar interruption, but that could also be an artificial finding after the preparation of the slides. So it's not necessarily emphysema. But what we see here is important in this bronchus. Take a look at it. It's dilated. It's looking enlarged. And it's having not a single layer of cells, but at some portions, multiple layers of cells. And if we take a look at the other bronchi here, because it should not be just a certain one, others should also suffer same changes to give this diagnosis. Again, beginning of multiple layers here, and here some spared amount of layers. Here, dilated vessels. And here, same change again. Bronchus, respiratory epithelium, and thicker place where the respiratory is also engaged with the formation of other layers. Some inflammatory infiltrates, which is affecting the sub and epithelial layers of the bronchus, enlargement of vessels with hyperemia, chronic inflammatory infiltrate in the form of lymphocytes, anthracotic pigment, here you will now recognize it. And pretty much that's it about this slide. Again, same changes here. Take a look at this here. Sorry for moving too fast. Respiratory epithelium, smashed respiratory lining, ciliated cells are not visualized here no more. And here we have multiple layers of other cells which more look like squamous epithelium. What will your diagnosis be here according to the idea that we have multiple fields of dilated bronchial structures, thickened bronchial wall with chronic inflammation, dilated vessels, and fields of metaplasia inside in the bronchi, which is actually squamous metaplasia. So what would that picture bring as diagnosis? Bronchiectasis, bronchiectatic disease. That's very correct. And pretty much that is everything that you should describe about this slide. So observe carefully the bronchi, which should be medium or large. Observe the vessels. Neighbor emphysema along with atelectasis of the alveoli, which is marked in pathology as I've wrote this one before. Dystelectasis. Sorry. This. Yes, that is the collective name of atelectasis and emphysema together, because compensatorily to fields of emphysema, logically there would be fields of atelectasis in the same pulmonary parenchyma. And what else? All of the things that we described so far shall be included also in this slide. Metaplasia, because these bronchi are dilated. The respiratory epithelium is desquamated. We have constant inflammation, and this desquamation brings to metaplasia. Very often in bronchiectasis, we observe metaplasia on the dilated and vulnerable places. Not because of smoking here, but because of terminal dilation of bronchiolar structures. That is again connected with dilation, but not yet. Mostly it's connected to loss of elastic fibers in the wall of the bronchi. It could be inborn condition. It could be medically connected condition when you, for example, when patients take some specific medications. I've seen how, for example, cortisone, which is a beta blocker as a medication, might be causing lack of elasticity in the bronchi, and those dilations, sometimes even looking like aneurysmal dilations in the wall of the bronchi, which is causing constant damage, constant inflammation connected with chronic bronchitis, and very often squamous metaplasia there, bringing very exacerbated night cough most of the times. But it's not related yet. But metaplasia is pre-cancerous condition that could be related to cancer. Further, since bronchiectasis are irreversible change, this dilation cannot go back. Once you damage the elasticity of a bronchus, it always stays this way. Do you have any other questions on this slide?